The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you. Hope everybody's having a great summer and enjoying family, enjoying the weather. Today I wanted to kind of take a few minutes and do a quicker podcast and talk about a topic that I think is very, very important. With all the review classes that we're teaching right now, this topic often really stimulates a lot of discussion, I think good discussion. And we have to kind of go back to the basics when we look at applying oxygenation. And I always use the analogies when we teach these concepts of when you started out in medicine, whether you're a nurse or a paramedic, you started out and you were taught, if you see this physiology, if you see this presentation, we're going to immediately apply oxygen, right? We give oxygen with a nasal cannula, we give oxygen via non-rebreather, we may intervene with a BVM. But really, do we understand what we're doing? And so we need to understand that in the critical care environment, we have longer times with our patients. We have to make a difference often. We're not just there to stabilize. We want to maybe try to progress and make a difference in their overall outcome. And we do that in a few ways. When we think about kind of applying ways to improve oxygenation, it's not about just simply applying a device. We have to get down to the root area where gas exchange happens, and I often use different gas laws, and specifically I use Henry's Law to demonstrate this. We've talked about this briefly on other podcasts, but let's just recap that. Henry's Law is a very powerful gas law, and Henry's Law states that the amount of gas dissolved in a solution is directly proportional to the amount of pressure exerted above the gas. Now, we often use that gas law as a representation of decompression sickness, but it's very applicable to O2 transport. If you combine Henry's Law with a gas law called Fick's Law, then you have all the ingredients to really optimize oxygenation where all the magic happens, and that magic happens at the alveolar capillary membrane. So Fick's Law deals with the thickness of the alveolar membrane. And I've often used the analogy of think of the membrane as a glass window. We want to make that glass window free of obstructions. We want to have good light going through. And so with that analogy, imagine your alveolar membrane. We want to make it thin. That's where Fick's Law comes in. Fick's Law is based on the thickness of that membrane. The thinner the membrane, the more diffusion potential you have. We apply that with Henry's Law. The definition is the amount of gas dissolved in a solution is directly proportional to the pressure exerted above the gas. Well, when we think about gas, we're talking about oxygen. When we think about, obviously, atmospheric air, we're talking about other gases, nitrogen, carbon dioxide. But for purposes of this podcast, we're thinking about oxygenation. So our liquid is our blood. Think about the blood in the capillaries. So we apply Henry's Law, and we do three things. We overcome partial pressure. Remember, partial pressure is Dalton's law. Partial pressure states that we multiply the atmospheric pressure by the FiO2 the patient is currently getting, and that's going to give you a partial pressure of oxygen. We have different measurements of partial pressure. We have PO2, which is the partial pressure of the overall environment. We have P little AO2, which is the partial pressure of oxygen in the arterial blood. And then we have P big AO2, which is the partial pressure of oxygen in the alveoli. So we have to know what we're thinking about. So let's just talk about P little AO2, right? We're talking about the overall bloodstream. And so when we kind of think about, we want to overcome partial pressure, we want to increase the concentration. So we just simply turn up the FiO2. Next thing we do, this is where Henry's law and Fick's law kind of intertwine. We want to make the surface area of the alveoli bigger. We do that by adding PEEP. So when we provide a good breath, or the patient takes a good, nice, big vital capacity breath, or if the patient is on a mechanical ventilator, we maintain that recruitment during exhalation. And third, we apply pressure. And that's simply, we've got to get the gas now through all the levels that it has to travel through to get to the capillaries, which it's 7 levels. Lots of epithelial tissue has to travel through your surfactant, has to travel through a basement membrane, has to go all the way through the glycocalyx that covers the surface of the vessels. And we get into the capillary where your oxygen molecule binds with your red blood cell, attaches to your hemoglobin. So I kind of segue with that into understanding your patient. We can get very complex when we talk about O2 delivery, and we can use the critical care formula of 1.34 times our hemoglobin multiplied by our SaO2. That formula encompasses the amount of oxygen bound to hemoglobin, right? The content, overall content bound to hemoglobin. And if we work that out, we would understand at the end that we deliver in normal homeostasis. If we have a hemoglobin, for example, of 15, we have a conservative SaO2 of 95%, we deliver about 550 mils of oxygen every minute. That's all already calculated based on a normal body index of 1.7 meters squared. So that's how much we're delivering in homeostasis. How much are we consuming? On the consumption side, we use the same formula, but we don't use an SaO2, we use an SvO2. So it would be 1.34 times the hemoglobin multiplied by an SvO2. And our normal consumption in homeostasis is around 200 to 250. Now that's without calculating body mass index. So if we calculate body mass index and we divide that by the 1.7 meters squared like we did previously, we get about 120 to 150 mils of oxygen every minute on the consumption side. So if we kind of compare this and think about something that we all know well, right? We have a certain amount of income every month. We have a certain amount of debt every month. The better off we are, we have more income than debt. And your debt-to-income ratio is smaller. So I want you to think of it in that way. A normal oxygen extraction ratio, so think of oxygen extraction ratio as your debt-to-income ratio, is 25%. Sometimes maybe a little less, 20% in some people, but 20 to 25% we can, safely say. When we think about income to debt, what happens if we add more debt and we bring that debt-to-income ratio up to 30%? In that manner, we have less reserve. We have less to put into savings, less to put into retirement. Same thing goes with your patient. So a normal O2 extraction ratio is 20 to 25%. When we start reaching into that 30% range, we start consuming more oxygen than we need. So if we go back to normal homeostasis, and I said we normally deliver, if you had a hemoglobin of 15 and an SaO2 of 95%, just using a conservative number, we deliver about 550 mils per minute. If we're only consuming 120 to 150 mils per minute, we've got a big reserve there. And what we're kind of talking about here is overall O2 delivery. And does our consumption outweigh our delivery? And that's where we get into delivering oxygen to our patients, right? Think of sepsis patients. Think of these ARDS patients. Are we meeting the demand? When you start progressing above 30% and you get into the 40% range, that's where we start teetering on going from aerobic metabolism to anaerobic metabolism. 40% is very worrisome. That's where your consumption is starting to really teeter on going over our delivery. We have to remember that we have to always optimize oxygenation. We have to utilize Henry's law to do that. It's not just about applying a nasal cannula, a non-rebreather. So how do we calculate an oxygen extraction ratio? Well, it's actually very, very simple. We don't need to do all these big formulas. You do need a few things. And if you have an AVG, or if they've identified a central venous pressure, you can, central venous oxygen saturation, I should say, you can do this very easy. And the way we do that is we will calculate your SaO2, right? You get your SaO2. You're going to subtract your SVO2. So SaO2 minus your SVO2 divided by your SaO2. So again, SaO2 minus your SVO2, take that answer, divide it by your original SaO2, and that gives you your oxygen extraction ratio. Remember, 20-25% is normal. You get to 30%, start kind of worrying. 40%, you're moving from aerobic to anaerobic metabolism, and that's going to be more of a systemic issue. So I just wanted to kind of put this in your guys' head. Think of what you're doing when you're applying oxygenation. It's not just about putting a device on. We have got to get down to the level where the magic happens, and that's the alveolar capillary membrane. Apply Fick's law, apply Henry's law. Those two intertwine, and think about that O2 extraction ratio. That will give you a high index of suspicion if you're meeting the demands of the patient. Just want to thank everybody. Thank everybody for the support. Got lots of classes scheduled, so check those out on the website. We've got classes now scheduled out to July of 2018. Fast 18 is approaching. Have a truly amazing lineup. Going to start really pushing the tickets. We only have a limited amount of tickets available. We've already sold a lot, so we're going to cap the conference at 400 people, so don't wait to the last minute. We do have a room block available at the Embassy Suites, the location where the conference is going to be at. Beautiful hotel at a discounted rate, and you can find that link on the website under the Fast 18 icon. Until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.